developed frameworks for psychiatric nursing. Okay, they're the background behind why we do what we do. Okay, obviously it's not just in psych. We have theorists everywhere. Okay, everywhere in every branch of nursing. Okay. So theories help us to explain behavior. I just said that. Therapies or treatments based on these theories. We're going to talk about cognitive behavioral therapy, right? An overview of theories and therapies and their relevance to nursing. That's what we're going to talk about in this chapter. Okay, let's talk about psychoanalytic theories first. Excuse me. I'm pretty sure we've all heard of Freud. Okay, I even think there's like a Netflix show on it. I don't know. Well, pretty sure we've all heard of Freud. Freud was all about dividing the human consciousness in 3 levels. He is all about your personality is developed at a certain age and you can't develop further. That's what Freud is all about. Okay? And he's all about conscience, preconscious, unconscious, right? Id, ego, superego. This is what this is. He believed that behavior and personality were derived from constant and unique interaction of conflicting forces. Okay, so your conscience, it's your memories, it's your thoughts, your rationality, how you think, right? Should I study? Should I not study? Right? Your preconscious, it's what brings you to your consciousness, the thoughts in the back of your mind, right? Your unconscious, it's the conflict, it's the unpleasant thoughts, it's the anxiety. And this is what leads us to id, ego, superego. Okay, it's the personality structure. Okay, so the id, it's the pleasure principle. Should I study or should I go out? Should I listen while my instructor is talking, or should I just watch? You know, I'm gonna meet myself. I'm just gonna watch whatever I want. It's the reflex, the primary process, id, right? It's doing what pleasures you, basically. Okay, then the ego, it's the realistic part of you. It's the problem solver, it's the reality, right? What's the right thing to do here? That's what it is. Okay, super ego is what makes you a good person. It's the morality, right? Good or bad. That's what makes you a good person, a good nurse, or a bad nurse. So id and super ego fight, and ego steps in. Okay, I'm not going to dive in too much because I don't really ask a whole lot about Freud. Actually, I don't ask about Freud. Okay, but this is good to know because you correlate this with your psych patients and you understand their ego, their superego, their id. Okay. We just talked about this, right? Formation of personality. He believed that through a series of childhood steps, we're going to talk about that. Conscience and conscious, we just talked about it. And then we're going to talk about attentive listening, transference, countertransference later on in the chapters. I'm not going to focus too much on it now. Okay. So, Freud thought that in these stages, your personality is developed. Okay, I'm pretty sure you've maybe heard of this before: oral, anal, phallic, latency, and genital stages. Okay, so 0 to 1. Okay, this is where everything has to do with the mouth. Have you guys noticed children until 1? Everything's about putting everything in their mouth. This is how they learn. Okay, eat, swallow, suck, mouth. Everything's all about that. Okay. They put something unpleasant in their mouth, they know not to do it again, right? It's a whole process. That's how that level, that part of their life is developed. Anal, 1 to 3, toilet training. Okay? Bowel, bladder control. So between oral and anal, possible ego develops around that time. Okay? 1 to 3 years of age. Okay? Then we got our phallic stage. This is where you get so curious about the general aspect of as you grow. Have you guys noticed children 3 to 6 years of age? They're so curious about that. They see maybe their sibling who's the opposite gender, and they always ask their mom, how come my brother has that and I don't? This is that part of the stage. Okay, the curiosity develops here. Okay, between phallic and latency stage, your super ego develops. 6 to 12. very approving to your family, to your parents, to the adults. So you focus on school, on sports, on being very active, on succeeding. That's where the super ego kind of develops there. So your libido is inactive, but you're all about school and achievements. Okay? And then 12 to 20, you're a mature adult, your sexuality has developed, you are who you are at this age, according to Freud, right? The personality is developed at 20 years of age, according to Freud. That's what he thought, right? Childhood personality, that's where it's developed, okay? I'm not gonna go over this question, it's not pertinent, it's okay. Let's go over Erik Erikson. I'm pretty sure you know who this is. I'm pretty sure you've done this in your care plans. So Erik Erikson said, excuse me, Freud, personality doesn't just stop at age 20, okay? It continues to develop through old age. It continues, that's what he said. And Erik Erikson categorized the ego theory that he had based off of age. And he provided a balance: trust versus mistrust, autonomy versus shame and doubt, initiative versus guilt, industry inferiority, identity role confusion, intimacy isolation, generativity versus self-absorption, integrity versus despair. So he said, not only do you develop past 20, but you don't always meet the stage that you're supposed to be at. Okay? So when you're studying for Erik Erikson, study the age, study the age group for each stage, okay? Study that, okay? And our psych patients don't always meet these stages, right? They could be, 35 years old, but due to their psychiatric diagnosis, they can be at the intimacy versus isolation stage. And they could be in isolation, okay? Or they could be 35 and they have to be in generativity versus self-absorption, but because of their psychiatric disorder, they can be in role confusion, which is from 12 to 20. Does that make sense, you guys? Right? I hope it does. Yes. Good. I'm not gonna, I basically just verbalize this. Erikson's theory, developmental model is important part of nursing assessment, helps determine what types of interventions are most likely to be effective. Basically, again, development continues as you age. Oftentimes, our psych patients don't meet them. That's what I just said. Yep. Sullivan. So Sullivan's interpersonal theory, he was all about interaction, okay? His belief is Sullivan's interactions with other people, especially significant others, right, determines the sense of security, sense of self-esteem, and interactions that motivate your behavior, okay? All about interaction. With psych patients, they oftentimes don't have that positive interpersonal relationships with others. So when they come onto the unit, we become that, okay? We become that, okay? So you become the relationship. So Sullivan was all about interpersonal theories, okay? Now Sullivan was the foundation for Hildegard Peplau, and she's huge in psych. We're going to talk about her in this chapter and then like one of the end chapters, chapter like 8. Hildegard Peplau, she was all about relationships, nurse-patient relationship. She developed the framework for a professional relationship between your psychiatric nurse and the patient. Okay, she was all about making this into an artwork. Okay, she was all about professional practice. Okay, she was an influence on the professional practice of current psych mental health nursing. Okay, with an emphasis on anxious and withdrawn patients. I'm going to repeat that because I'm so nice. Okay, Hildegard Peplau was all about professional practice, okay? Influence on the professional practice of current psych mental health nursing with an emphasis on anxious and withdrawn patients. That's what she was all about. All about relationships. That was her. The science of nursing, application of knowledge to the broad range of human problems. Intervene. You have to intervene in order to promote self-worth and promote growth for your patient. That's what she was all about. Nope, that's her. Behavior theories. Excuse me. Pavlov, Watson, and Skinner. I'm pretty sure we've heard of them. Okay? So these guys protested Freud also. And they said, no. Okay? Behavior doesn't just develop until age 20. You can change behavior. They felt that changing behavior was the key to solving problems. Okay? So we utilize this, right? We believe that changing behavior is a key to solving problems such as anxiety, depression. So behavior is learned and what? It has consequences. And that's where these guys come in. So Pavlov's classical conditioning theory. You guys know the dog salivating? This is where he bangs that chime. And at the sound of the bong, the dog salivates and the food is presented. You guys know this, right? Yeah. So two stimuli are linked together to produce a learned response. That's what Pavlov is all about. Watson's behavioral theory. Okay, so Watson, behavior can be conditioned based on presence or absence of external stimuli. So this guy believed that he can take away any child and train them to become anything. So I can take you at a young age and I can train you to become whatever the heck I want you to become. Behaviorism. That was what he thought about. That's what he believed in, okay? Skinner. Good behavior is followed by pleasant consequences. Shaping behavior through reinforcement. So this guy, you guys know the Skinner box? Have you guys heard of that? So designed to teach rats how to push a lever. Once they do push the lever, they get food as a reward. If they don't push the lever, they get electrocuted. Do you guys remember that? Or have you guys heard of that? Pretty famous, pretty famous. All of these guys are pretty famous. Yeah. So basically they are all about modifying behavior, okay? Cognitive behavioral therapy, we're gonna learn about that. We're gonna change our behavior to become better, to become more positive. We didn't study so much, we didn't do so well, so we're gonna change our behavior. We're gonna study more, we're gonna pass the class. Does that make sense? That's what these guys are all about, okay? I really wanted to include this because Office fans, do you guys remember this? I only have he actually did the Pavlov prank on Dwight. How fun is this? Okay. At the sound of what the computer shutting down, Mint started to salivate. I think it's very clever. I love it. I have to say that my Tuesday class, more Office fans in my Tuesday class. I should make this extra credit. You guys have to watch The Office to pass the class. Just kidding. Some behavioral therapies that we utilize in psych: modeling, operant conditioning, systemic desensitization, aversion, biofeedback. Let's go over them briefly. Excuse me. Modeling, role model for the client. Imitate behaviors so your client can treat you the same way. We utilize it all the time. We do this with children a lot. If we work with kids, we do this a lot. Okay? Operant conditioning, positive rewards for positive actions. We utilize cigarettes a lot for our psych patients. It's like holy grail. Means we're going to go out for a cigarette. Okay? Systemic desensitization, planned exposure to anxiety-provoking type situations or things. Use relaxation techniques to reduce anxiety. So we use this with phobias a lot. Okay? So if I'm afraid of spiders, I will gradually be exposed to them, systemically desensitized, until I become confident and less afraid. We use this with phobias a lot. We use this with anxiety-provoking situations. Okay? Aversion therapy, bad behavior with a punishment. You disrespected the patient's on the unit, you disrespected the nurses, okay, I'm gonna confiscate your cigarettes. We do that a lot. It kind of works. It works for our psych patients. Okay? It works for our psych patients. We do this with children a lot too. Those of you who are moms, you guys utilize this too, right? I mean, I'm not a mom, but moms do this, right? All the time. Yeah. Interesting. Doesn't work all the time though. And then if it doesn't work, what do you guys do? Yell. I know my mother yelled at me as a child. That worked. But obviously inside. Take everything away. Yeah, exactly. Time out. Right? I'm not gonna dig deep into these behavioral therapies because as we go along in the term, we're gonna talk more about them. Okay? Cognitive theories and therapies. Now kids yell back at us. Yeah. I don't know, in my household, that is not acceptable. Even at my age right now, I can't do that. Very cultural too, wouldn't you guys say? I don't know, I think. Yeah. So, Ellis and Beck, definitely cultural. Ellis and Beck, okay? So, rational emotive behavioral therapy, and cognitive behavioral therapy. You guys are gonna hear me say CBT all the freaking time, okay? So, what the heck were these guys about? We utilize this all the time in psych. So, Ellis, REB, rational emotive behavior, aims to eradicate irrational belief. He targets irrational beliefs and patterns that may lead to emotional behavior issues. This is all about targeting what the heck is that thought that makes you think irrationally. Let's find that. Let's look at that thought process. Let's find the thought, the belief that makes you think irrationally. What makes you think you're going to not pass this class? What makes you think you're going to pass? That's what Ellis was all about. Then cognitive behavioral therapy, he was all about changing clients' attitude toward life. So it's this therapeutic approach, seeks to help the patient overcome difficulties by identifying and actually changing the thinking process and the behavior. Okay, this is where we start to help our patients use coping mechanisms, changing their belief systems. Okay, the therapist comes in and the therapist is trained to do this, utilizes this. Okay, cognitive behavioral therapy. So Ellis is all about finding that irrational thought. Beck was all about, okay, let's find it, now let's develop mechanisms to change it. Okay, develop skills to modify beliefs. Okay, that's what they were all about. Maslow. Maslow is how you pass your NCLEX, by the way. Airway, breathing, circulation. Need I say more? Okay. Maslow's hierarchy of needs. Human beings are active participants in life, striving to self-actualize. So when lower needs are met, higher needs emerge. So I'm sure you guys have seen this. Is your screen blank too? Oh, there it is. I'm sure you guys have seen this, right? So basic needs first. If your patient says, I can't breathe, that's priority. I don't care about anything else if my patient isn't breathing. So once you're breathing, you've got sleep, you've got water, you're sheltered, you've got food, then you move on to safety. Once that's met, you move on to love and belonging, self-esteem, self-actualization. Our psych patients, oftentimes, they're stuck between safety and love and belonging. They don't meet those categories, right? Now, I don't care what scenario you see on the test. If your patient says, I cannot breathe, you choose that one, even in psych. Am I making sense, guys? Yeah. I know I'm making sense. Okay? So once they satisfy one need, another need emerges. Once they satisfy that one, another one emerges. Cool, right? Airway breathing, circulation. I thought I'd include this. If you're an office fan, you will understand it. Maslow's hierarchy of needs plus the office, right? I never thought this was in for the money. You belong on the Maslow's hierarchy of needs. Like the first one along with oxygen. No? Okay. Biological theories. Consider other influences that play a role in development and treatment of mental disorders. Right, we talked about this. Remember diathesis stress model, right? Genetics comes into play, environmental, economic, cultural. Although we've learned that genetic gives you a higher predisposition, environmental vulnerability, how you were raised, right? Doesn't matter what demographic you're from, right? Whether lower economical status or higher, we're going to learn throughout this term that mental health affects everybody. Okay, everybody. Social, environmental, cultural, economic focus on qualities of therapeutic relationship, understanding the patient's perspective, communicating to facilitate recovery. When thinking of biological or environmental type theories, it's all one whole holistic approach. Okay, I'm not going to focus too much on it because this is all about diathesis stress model, and we've discovered and learned that it's all about nature versus nurture, right? Now, milieu therapy. Who's heard of this? Who's heard of milieu therapy? We have to utilize this everywhere in nursing. Okay, milieu therapy is a total use of your environment to create a positive structure to provide positive possible care. We're going to learn in the next chapter that your psych patient is already what? Locked. They already can't go anywhere. So you're going to utilize everything in your power, whether it's music, writing, journaling, physical activities, everything, positive, bright colors to facilitate that positive milieu therapy, to provide healing, a positive environment. Am I making sense, guys? Just like I'm trying to do now. I'm trying to create this positive milieu therapy so you guys won't be so stressed out. That's what this is. Healthy environment combined with social structure within a patient's setting. Okay? What do you guys think of when you think of a setting, a psych setting? Those of you who haven't been to a psych ward, what do you guys think? What do you anticipate seeing? Anybody? No right or wrong answers. Like you can even, kind of scary. Okay. I hope that can change. Less objects in the rooms. Why? Why, guys? I wonder why. Who can take a guess? Safety. Mm-hmm.
Gonna be less distraction. Like when you're everything minimalistic.
It's less distracting. Also, it's a safety issue. With psych patients, they can take anything and they can harm themselves or others. Yeah, and it is less distracting, less stimuli. It's perfect. Less stimuli, less distraction, less stimuli. They can hurt themselves. I almost wish I was your clinical instructors, guys, because I don't want you guys to have this idea that it's scary. Okay, it's not. It's just a different approach. Psych patients love nursing students because they talk to you guys nonstop. But we have less stimuli, we have less objects. I want you guys, when you guys go to the site, pay attention to no shoelaces, the wires of the bra removed, because these are things they can use to hurt themselves and others. If I'm going to give them a plastic fork because I'm going to watch them eat, I want to make sure I get that back. Very minimal in that sense. If they bring in their makeup, I'm going to watch them do their makeup because they can use that to harm themselves, right? Or others. If they're going to shave, I'm going to watch them shave. So very minimal in that sense. But, white walls, okay, maybe like bright colored walls. I don't want you guys to think of movie scenes. It's very different. very open environment. There's a common area. There's a TV going on. We utilize what? Karaoke, music, what else? Movies, right? That type of environment. But it's all about safety and it's locked. We're going to talk about that. Okay. But especially since it's so controlled, this is why milieu therapy comes into play. Okay. This is why milieu therapy comes into play. I hope I made sense. Okay. I love that you guys are participating. Thank you. Do you guys know this? Which one's Pavlov? Let's use the chat box. Which one would that be? A, 1, 2, or 3? 3. How about Watson? Skinner. Yeah. I'm not going to go over this. Let's push through this chapter and then we'll take a break and then we'll come back to continue. We're good on this, yes? Right. Okay, treatment settings. We're going to talk about what the heck. We just briefly discussed our treatment setting, right? Our classic psych treatment setting, locked unit, utilizing everything, positive environment, very open, doors are never closed, right? If they're on a one-to-one, we're going to talk about this a lot for safety reasons, closer to the nurse's station, right? Very positive-like environment. It was never like that before, okay? Look at this, okay? Wet wrap therapy was utilized before. Isn't this nuts? A calming measure. So your water was basically heat up to a certain temp. You know, I haven't seen that. I should watch it. Everyone says it's good, Nurse Ratched. But I'm gonna watch it. I have to. I have to. I keep saying I will and I don't, but I have to. Yeah. Isn't this insane? This was supposed to be a calming measure, right? Right now we have all these meds we utilize. We have a different therapeutic approach. But this is what, does this look humane to you guys? I'm terrified. I'm terrified. And then we have insulin shock therapy. Scares those who are afraid of water, that's for sure. Yeah. What really shocks me is this. Insulin coma therapy, a form of psychiatric treatment in which patients were repeatedly injected with large doses of insulin in order to produce daily comas over several weeks. Guys, let's bring in that med-surg knowledge that we have. I mean, what the heck? You are busting organs here. Can you imagine? This was in the US. Yep. This was in the US. We've come a long way. We've come a long way. Right? Atrocities. You know what's funny? You said this was in the US. My mom was a nurse in Russia. And when she was hospitalized here for whatever reason, she was like, I can't believe they're so nice here. So her idea was like, in other countries, it's probably still like this for psych patients. Yeah. Large doses, guys. Look at this. Release of evil spirits that inhabited the head. Oh my gosh, you guys. Aren't you guys shocked? I am. And this is, yeah, World War II flashback. This is insane. Yeah. And then, moving on later in the US, institutionalized without due process, deprived of liberty, without appropriate legal measures. It's changed, guys. Our psych patients have rights. Before, they had no rights because they weren't deemed to be human. Huh? That's changed, but before, they were just institutionalized. You go to prison, you get locked up. Okay? Now, that's no longer the case. Okay? That's just no longer the case now. Okay? We have suicide helplines, we have behavioral helplines, we have psych eval teams, the PET team. We're going to talk about holds 5150, 5250. We're going to talk about the next chapter. We have emergency services. If anything happens, even if there's a psychiatric emergency, you call 911, they take you to the ER, you can get hospitalized. Then you have outpatient services. I mean, look at the care we have. Then we have online services. I'm sure you guys are doing 7 cups, right? We have telepsychiatry, we have internet, we have telephone outreach, we have everything available for psychiatric help now. We're no longer drilling holes in heads, okay? There's no longer insulin therapy. That's not utilized anymore. So we've come a long way. And a lot of people have access to it. And we're slowly but surely leaving the stigma, okay? Slowly but surely leaving the stigma of mental health behind us. Cool, huh? and we have this multidisciplinary treatment team approach. One patient, how is safety ensured for nurses in mental health hospitals? You're talking about the behavior, right? Because of the patient's behavior. You know what? You learn as you go along the way when you're a psych nurse. You are taught behavioral techniques and how to keep yourself safe. You are taught therapeutic communication. You are taught to utilize the meds that are within your power. All of it is within a legal aspect. You are taught all of this to keep yourself safe. Yeah. There are obviously incidences where harm is inevitable. But let me tell you guys something. I don't know if you guys can tell, but I'm small in stature, okay? But when I walk onto the unit into my patient's room, my patient is afraid of me. Now, when I say afraid of me, I mean this in the positive most way. I develop a relationship with my patient where if they start to escalate in behavior, I know how to de-escalate them because they trust me. Trust me, okay? They trust me, they respect me, and I respect them. So that's how you ensure your safety, okay? I know when to put my foot down. I know when. It's all about how you present yourself. It's utilizing your meds, your therapeutic approach, your therapeutic communication, and your team as a whole. You never work, you're not a lone wolf. Okay, you work together. Does that make sense? So each hospital, we're on the nurse's side. We're on the nurse's side. We work together, and you also develop your own skill. Does that make sense? I hope you have you get the idea. Yeah. It's very interesting, guys. It's very interesting. I've had patients tell me, oh my gosh, you're not playing games. So psych patients are very good at manipulating the crap out of you. So as you progress in your nursing career, you learn. You start to recognize you have like a bullshit meter. Is my patient bullshitting me? Are they not? You start to figure this out. You become confident. Yeah, it's fun, guys. It's fun. Yeah, and I said you're not working alone. You have this multidisciplinary team. Okay, you have the MD, the medical doctor. You have the psychiatrist. Then you have the nurses, then you have the therapists, then you have recreational, occupational, dietitian, pharmacist. We have all these people caring for one patient. Can you guys believe it? We've come a long way. I think this is incredible. Okay? I think this is incredible. Excuse me. I'm not going to dive too in depth because we all should know primary, secondary, tertiary prevention of care, right? I'm pretty sure we mentioned, not we, but I'm pretty sure it's been mentioned in MedSearch. There's always a primary prevention, there's always a secondary prevention, and tertiary prevention. Seeks to reduce incidence, right? You educate, and that's your primary. Educate. Let's get educated. Secondary is where you screen. Who has this problem? Let's screen. Okay. Tertiary, you already have this problem. Let's treat it and let's make sure it doesn't progress and become worse. Okay, that's all this is. I'm not going to dive too in depth. Okay. I'm not going to talk about this case study. I'm not going to waste your time with it. I have 2 more chapters to cover, and we're so good on time. Come back. Class ends at 11, right?